Amen. Right, and y'all keep April in your prayers. She is trying to recover from a little accident, and she is unable to be with us in person, but she can hear us and we can talk to her.
Okay, Mr. Chairman, sorry, Representative Oliver, I'm calling the roll. We have Representative Oliver, Senator Weaver, Representative Gray, Representative Moore, Senator Chastain, Senator Coleman, Hobby, Dr. Parker, Ms. Colley, Mr. Wells, Dr. Embry, Dr. Agarwal, Mrs. Sprayberry, Dr. Garvey, Dr. Ovalle, Dr. Hess, and Mr. Cameron. Mr. Chair, you have quorum.
Okay. Uh, Today we have a speaker that we're very proud of, and we're going to learn about the Alabama Medicaid Agency. And Barry Cameron was the presentation, but we'll take whoever we get from Medicaid and be very happy. Go ahead. And the purpose today, we're going to try to move quickly because we want to have time to ask questions, and that's why we only have one speaker today. We're trying to get a little more value out of this.
Thank you, Representative Oliver. I appreciate the opportunity to present on behalf of the Medicaid agency and learning from the task force members today and hopefully disseminating some information. I look forward to this discussion. I'll try to keep the presentation relatively brief, but I'll gladly answer any questions that I possibly can, and if I can't, we'll make sure someone at the agency gets back to you. My name is Barry Cameron. I am Deputy Commissioner of Health Systems at Alabama Medicaid. I'll start the presentation by saying I am not a clinician. I do have oversight of several programs within the agency, including the Alabama Coordinated Health Network, otherwise known as the ACHN program, which I'll speak to today. I also have responsibility for our analytics division, among others. So again, if there are clinical questions, I will make sure that if I can't answer them, I'm sure our task force members will be able to answer a lot, but also our director of pharmacy and our medical director at Medicaid. So with that said, I do want to start off with a very high-level overview of Medicaid today. I'll talk about some statistics relative to obesity rates and prevalence rates within the state and by region. I'll discuss some of the current initiatives that the agency is already undertaking and has undertaken to address some of the issues that we're trying to address today, such as type 2 diabetes as well as obesity. And then finally, I'm going to talk a little bit about where the agency is with respect to mandatory coverage as well as what we're calling optional coverage for GLP-1 drugs. And then, of course, I do want to reserve as much time as possible to take questions from this group. So we'll start off at a very high level with Medicaid. What is Alabama Medicaid? Believe it or not, there's a lot of people that work within Medicaid at times that still refer to us as Medicare. So we are not Medicare. Medicare predominantly covers the over 65 population. We are a federal-state partnership that provides health insurance for people with low incomes and a lot of the disabled population. This program has been in place nationally since 1965. In fact, yesterday it turned 59 years old. And federal law essentially sets the minimum eligibility and benefit requirements for some states and does provide a significant portion of the funds for the Alabama program. Currently, our what's called our FMAP, or federal matching rate, is around 73%. That varies year to year, but we rank probably in the top 4 right now of states with the highest FMAP percentage. So again, as I mentioned, Medicaid is not Medicare. We do not directly provide medical services. However, we do pay providers that do provide these medical services. And essentially what we are is a health insurer. And what I've added is a health insurer that invests in quality. And specifically, I'm going to talk about the ACHN, the Alabama Coordinated Health Network, as something that I think is innovative in this country and something we're very proud of. I'll talk about some of the impacts on the state. I cannot overstate the impacts, but with 4 bullets certainly. But we serve currently more than 1.1 million recipients. In any given year, a citizen in this state is eligible for Medicaid. At least for 1 month of the year, that number grows to about 1.2, in some years, close to 1.3 million. And that represents about a quarter of the state's population. Uh, More than half of the births in the state are covered by Medicaid. We have a little less than 60,000 births a year in the state. That number has been relatively flat for a while, and Medicaid typically pays for about 31 to 32,000 births. More than 50% of the children in this great state are covered by Medicaid. We have more than 600,000 eligible children under the age of 21 eligible for Medicaid. And then finally, as of the end of fiscal 23, we are approximately a $9 billion agency, obviously one of the largest agencies in the state. Again, we do have roughly a 73% federal match for that, which I'll talk to that a little bit later on in the presentation. And then finally, in terms of our Medicaid overview, this chart just simply illustrates the distribution of our dollars spent as well as the membership relative to eligibility and age groups. So as you can see in the chart, our disabled and blind categories, and that can be any age. In fact, these are determined by the Social Security Administration. We have about 5,000 to 6,000 babies actually that are considered to be SSI eligible. That represents, in any given year, close to 20%. Right now, it's about 18% of our total eligibles or membership, yet it represents a significant portion of the spend, not surprisingly. A lot of nursing home care is delivered to this age group and hospital care. And it represents a little less than half of our spend, or about $14,000 per member per year. As mentioned earlier, we cover more than half the children in the state, and as far as the 18 and under category, it represents a little bit more than half of Medicaid's membership and represents about a quarter of our total spend. And our children typically are around $3,000 per member per year. Our age population, this is our over 65 population. You're gonna hear me refer to dual eligibles, and what that means is we have eligibles that are dual Medicare and Medicaid eligible. And Medicare pays the majority of the cost for these recipients. Medicaid pays the premium. It's somewhat nuanced, but essentially it does represent a significant portion of our spend, 15%, but less than 8% of our total members. And then finally, we have just an other adult category, and this is the age group 19 to 64. And this includes our pregnant women aid category. This includes our family planning population and what we call the parent caretaker eligibility group. And these are essentially able-bodied adults that have a full-time caretaking responsibility. Obviously, this group represents a big part of our membership, but represents only 14% of spend, as a lot of these eligibility groups are not full benefits. And they're about $3,600 per year. Next, I'll move to some statistics relative to the Alabama Medicaid population around both obesity and diabetes, specifically type 2 diabetes. So what this map shows, this is a lot of data to take in, but what this shows is by region, and for illustrative purposes for this map, this is by our ACHN regions. And again, our ACHN I'll cover a little bit later on, but it's a statewide system of case management that is essentially delivered by 7 entities in the state. And so we have separated the regions of the state for illustrative purposes, but of the entire Alabama Medicaid population, at least for those for which we have a claim, are with a BMI measurement. That is not all of the claims, but it does represent more than 60%. We have an internal policy in place at Medicaid where providers are incented to document the BMI rather on the claim. So we do have a statistically significant portion of a fairly representative portion of our population when we run these numbers that we consider to be in line with statewide statistics and in some cases national. So of the total Medicaid population that does have a BMI claim, 42%, and this includes adults and children, 42% would be considered obese or they have a diagnosis of obese. So the claim will either document a BMI of greater than 30 or diagnosis of obesity. Of our adult recipients, 64% are diagnosed with obesity or have a BMI greater than 30, and of children, that number is one-third, or about 33%. If you look at the map, again, I'll get into this a little bit later on with the ACHN program, but these districts, these regions were developed for a lot of reasons. Patterns of care was one of them. Scale for all the statewide entities, the ability to serve an equal population base. But there are stark differences with a variety of different health outcomes metrics. But specifically with obesity, you see, if you look at the orange, what we call the Northwest region, and the aqua region in the center of the state, the central region, there you will tend to see our higher prevalence rates for both children and adults, and these also happen to be a good portion of our Black Belt counties. I would also note, we also ran some numbers on the recipients that do have these diagnoses of obesity, and about half of them in the total population, a little bit less than half, have an additional 3 chronic conditions that are associated with them. And again, those tend to be exacerbated in our Black Belt region. Next, we'll talk about the diabetes prevalence in the state. This map is at the county level as opposed to the regional level. And I want to start with a disclaimer. So at this point, this does not represent diabetes as indicated by any lab result. These are all diagnosis-based, so it's claims-based, administrative-based. So there are caveats associated with that. And again, I think it's important to note of this total number, we have excluded the dual eligible population, which represents a significant portion, specifically the over 65 population, and some family planning and maternity recipients. But currently we have about 38,000 recipients that are diagnosed with type 1 or type 2 diabetes. About 5,000 of which, and on a claim, it's really hard to be precise with this, but about 5,000 have juvenile or type 1 diabetes. And again, similar to the map and the charts that you saw before, based on the region of the state, based on the county you reside in, you tend to have a higher prevalence rate. And again, if you look at the dark blue counties, that represents higher incidence, higher rates of diabetes, and again, a large part of the Black Belt where provider access is an issue and a lot of other socioeconomic factors are at play. There's other basic statistics here in terms of age group. 88% are adults, not surprisingly. A fairly equal mixture of race. About 41% of the diabetics are Black, about 38% are white, and that tends to be in line with the overall Medicaid population. Any given year, we have about 40% Black, 40% white. It varies by a point or two, and then 10% other. So these numbers are consistent with our overall population. And then finally, a larger proportion of females. That's probably more or less attributable to the membership mix and the fact that Alabama is currently not an expansion state, and therefore there's not a there's not a lot of able-bodied males. So now I'm going to talk about a few initiatives that the agency is currently undertaking and has been undertaking for the past 5 to 10 years to address some of these issues that we have been discussing for the better part of a year now. So again, I mentioned earlier I would go into a little bit more detail on the Alabama Coordinated Health Network, or the ACHN. This is a program that began approximately 5 years ago. And essentially, in its most simplistic form, it's a statewide system of care coordination and case management. I mentioned earlier that there are 7 regions in the state that's fairly equally distributed in terms of population. I would note that 3 of the regions are owned or operated by Viva, a UAB organization. 3 of the regions are owned by subsidiaries of Blue Cross of Alabama. And then the dark blue counties in the northeast part of the state, those entities are owned and operated by the Huntsville Hospital System. So I think we have a very well-rounded picture of the state in terms of both medical and administrative leadership representing us and under contract with the Medicaid agency. And so essentially when this program began 5 years ago, there were three overarching goals that we wanted the program to deliver, and we track the outcomes of the program. We have several quality measures that we use to incentivize not only the ACHN entities themselves, but of the 1,000 plus or so participating primary care physicians as well as OBGYN physicians. But there are three overarching outcomes. One is prevention of childhood obesity, and I'll get into a little bit more detail on that later. Second is infant maternal mortality. And finally, substance use disorders. I don't think it's a surprise to anyone in this room that Alabama is a state, and Alabama Medicaid, relative to our peers historically, has been at the bottom or near the bottom in rankings relative to the rest of the nation. So these were the three outcomes we wanted to be intentional about when we developed this program 5 years ago. So again, currently it represents about 800,000 of our recipients. Again, that's more than 80% of the Medicaid population, and essentially it is our general population, which is children and not basically non-disabled elderly adults. Uh, and the maternity and family planning population is represented as well. I would note also that, and I'll talk about some of the quality programs related to childhood obesity, but we are beginning a new contract with the ACHNs. We're still in procurement, so I can't say too much about it. But beginning October 1 in 2024, just a few months from now, the new program, per the requirements in our RFP, will be stratifying recipients with a BMI of 40 or greater, essentially the morbid obesity diagnosis. And basically what that means is it qualifies all these these recipients as high risk, and it means they will be, if they are enrolled in the program, delivered a high intensity case management. So we are putting a more specific focus not only on the childhood obesity problem, but on the adult population as well. I'm not going to get into all the details, obviously, on this slide, but each of the seven ACHN regions, and there's six up here, so I hope the region that's left out is not offended, but to fit them all on a slide. But basically, uh, they are mandated to deliver on what's called QIPs, or quality improvement projects, on an annual basis. We have an external auditor that monitors that, and we work with the ACHNs to change these on literally a quarter-to-quarter basis in some years. But these essentially are quality projects that the agency essentially reimburses them to apply. And we wanted to make it regional. The agency does approve them, but we want to give the ACHNs discretion relative to how they think community resources or other types of incentive programs can help them move the needle on these metrics, and in this case, childhood obesity. So I'll just mention a few here. Alabama Care Network Mid-State. That is an entity that is owned and operated by Viva or UAB. One of their childhood obesity quality programs that they have had in place for almost for the last 3 years, I want to say, is offering UAB dietitian services as often as weekly for up to 6 months or until the recipient graduates from the program in some cases. Another example is North Alabama Community Care. It's the bottom right box. As you can see there, again, that is owned and operated by the Huntsville Hospital System. And again, this is a program that has, for the most part, been in place, been in existence since the outset of the program. And they have what's called a childhood obesity food box program, and this is for all recipients, not just children that have an overweight BMI, and it delivers healthy eating and food boxes, and encourages not just the children, but the caregiver, the parent, healthy eating habits and active lifestyle coaching. And then I'll end with MyCare Alabama Central. Again, this is represented by AlaHealth, which is the parent company, or excuse me, a subsidiary of the Blue Cross Blue Shield Association of Alabama. One of their initiatives that they're particularly proud of is what's called the Strong Mama program, and that is an evidence-based practice to promote breastfeeding. And there's lots of evidence. I think most of you would concur that breastfeeding at an early age, particularly for first-time mothers, does have a long-term impact on obesity. So those are just a few. There's obviously a lot of room to grow with all of these programs, with all these metrics. But again, it's something that the agency monitors. We monitor quality, and we have put a payment system in place that reimburses, that provides incentives for hitting certain health outcomes. So in terms of our current initiatives, I'll end with this slide. This is one that I wouldn't say caught me by surprise necessarily. We have obviously been covering GLP-1s for about a decade now in Alabama Medicaid for type 2 diabetes. But the significant growth, not only in terms of recipient spend, as well as a dollar spent in the last 3 years, is fairly striking. So as you can see on the chart here, I'll go slow here because there's a lot to absorb. There are currently 7 GLP-1 agonists that we cover for recipients with type 2 diabetes. I won't go into all the names there, but they're in the bottom left part of the chart. Uh, Spending for these GLP-1 agonists has increased from 1.2 million in 2014 to at the end of last calendar year, 2023, 59 million. Now, I would say that is our total, what I'm going to call total computable or total gross cost. In other words, this does not factor in any type of federal or state rebate, and it represents the total spend, not just the state share. But nonetheless, going from 1.2 million to 59 million in 10 years is striking. Recipients that have been utilizing these drugs have increased from under 1,000, under 700, in fact, 10 years ago, to close to 11,000 at the end of calendar year 23. And the average spend per recipient has increased from just under 2,000 to 5,300 in 2023. And one of the questions I assume that some of you might have, I don't want to assume that, is, you know, how are these drugs working for our recipients with type 2 diabetes? The evidence shows that they do work, obviously, but the agency, the analytics division, in concert with one of our university partners, is undertaking an outcome study that will follow a lot of these recipients and track different outcomes. So we're in the preliminary stages of that, and so I would entertain any feedback and welcome any feedback from the members. So I'll end with what we're calling mandatory and optional coverage of GLP-1 agonist. And I'll start with the federal drug rebate program. I want to give a little bit of background before I get into the details of this slide. So what the federal drug rebate program does in its most simplistic form is require manufacturers, if they cover Medicaid recipients, to offer federal rebates to offset the cost of both federal and state dollars for state Medicaid agencies. And in return, generally speaking, states are required to provide coverage for all FDA-approved outpatient drugs, called covered outpatient drugs or CODs, for manufacturers who participate in the federal drug rebate program. There is exceptions. There's a few exceptions, and these are subject to accepted indications, and we'll talk about those and what has changed. And I'm mentioning Wegovy here because this slide is taken literally from a CMS, what's called an all-state Medicaid call. CMS conducts monthly calls. Typically, the director of Medicaid, CMS nationally, the director of Medicaid facilitates the call, and CMS has their subject matter experts participate. And it's a variety of topics every month. But a few months ago, of this call talking about GLP-1 agonists specifically for weight loss, and then ultimately for weight loss as well as cardiovascular conditions. And so I'm using Wegovy in this example because it is how CMS walked the states through how this works. So again, I mentioned certain drugs or medical uses of a drug may be excluded from coverage if a medically accepted indication is subject to restriction. So the original FDA indications for Wegovy was essentially it could be used for chronic weight management in adults with a BMI of 30 or greater, as well as 27 or overweight with at least one weight-related comorbidity, excuse me. And this was one of the exceptions. Weight management, I think CMS called it weight loss or weight gain, as well as anorexic type of conditions were subject to restriction. So therefore, states were not required to cover this particular drug for purposes of weight management only or weight-related conditions, if that makes sense. That was the original FDA indication. In March of this year, The FDA added an indication relative to cardiovascular events, which does fall under the coverage standards, which does mean that states are required to, in this case, cover Wegovy, a GLP-1 agonist drug, uh, if there's a diagnosis of obesity still, but a risk of cardiovascular disease in these adults who have obesity or are overweight, a BMI of greater than 27. Some of the other label indications included adults and pediatric patients aged 12 years and older with obesity, as well as adults with overweight in the presence of one weight-related comorbid condition. So the Alabama Medicaid Agency began covering Wegovy in the last few months, and I do think we have began to fill prescriptions for this drug. And so that is when I talk about mandatory versus optional coverage, that's what I'm referring to. Okay?
Can I ask just when you started covering? I actually had a doctor that asked me about this last week.
Yes, ma'am.
When did you start covering Wegovy?
Uh, I don't have the answer off the top of my head. We'll get that. We'll get back to you on that, but I want to say it's been in the last 4 to 6 weeks.
Thank you.
Sure. And I'm sure some of the members on the task force could probably answer that as well. So let me talk first about, I'll start with, so when we started covering this, we do have, the state of Alabama does have our own PA criteria in place for this. I won't get into all of the details, but it sets a certain BMI range. It sets the parameters around certain diagnoses, past cardiovascular intervention events, and a few others. And our age requirement at this point is 18. Okay, so a lot of states have gone off-label, if you will, in terms of the PA requirements and the PA criteria that's in place to cover this. So that just gives context for when I show what at least the financial impact to the state could be, what we have in place that is again going a little bit off-label from Wegovy. So, and I'll get to that on the next slide, some of the financial projections. But I also wanted to go back to the state coverage of GL1 agents for obesity or obesity-related conditions. This slide might be a little bit dated. The last study that we were able to obtain is from the Kaiser Family Foundation. They published a study at the end of calendar year 2023. It surveyed all state Medicaid programs, and they tend to have a close to 100% response rate from states and territories. And as of July 1st of 2023, 16 Medicaid programs had reported at the time of covering at least one AOM for the treatment of obesity for adults. And essentially, the specific language in the survey asked states to identify whether they covered anti-obesity, and this is taken from the questionnaire, or weight loss medications for adults when prescribed for the treatment of obesity under fee-for-service. And so again, I think that number has grown to maybe to probably 18 or 19. Again, I could be mistaken. That's information that we could get back to the task force, but there's more than a dozen states currently covering it with different criteria in place. And these are just two examples. There were several examples in the study for those that are interested, and a lot of these are probably dated, I would add. Mississippi is an example. They are subject to prior approval and only one covered product at a given time. And they have what's called a three-phase approach for the medication treatment of obesity. There's the initial authorization. Again, they have a PA criteria in place where patients must qualify for this drug treatment. There's a reauthorization process where essentially the patient is reevaluated on a frequent basis by their provider, and then ultimately maintenance from working. And then Virginia, again, just one example of several states. They do require providers to attest to the patient's obesity as disabling and life-threatening. They do require a BMI of at least 40 or a BMI of at least 30 with 2 or more chronic conditions for their approval of GLP-1 agonist. So states that have opted to cover this, at this point, a lot of them have put in different criteria in place for a lot of reasons, one of which is to mitigate costs. So what I'll end with, and this was asked by a couple of the members of this task force, is has the state done any calculations? And the answer is yes. We are constantly doing essentially what we consider to be financial impacts to the state. So we look at state and federal dollars. But I'll start with the left-hand side of this slide, which is as it stands today, and literally these numbers change month to month given experience from other states, other data that comes in. But the projected annual cost for essentially the mandatory coverage of Wegovy is seen in this chart below. Again, I mentioned some of the criteria that the agency has in place. Uh, we'll begin to know more. We've been covering this for several weeks now, but we'll begin to know more probably after 3 months, probably 5 months to account for claims run out. But given the criteria that we have in place, again, for the mandatory coverage of Wegovy for diagnosis of obesity, cardiovascular conditions, as well as prior events, exclusion of type 2 diabetics because they are already covered by several GLP-1s, we have run conservative and aggressive scenarios. And I would say we are probably more comfortable with the optional coverage on the right, which I'll get to in a moment. The reason I say we're more comfortable, some of the data is more robust than others, but for this, a lot of states are in the same situation as we are, where they have only begun to cover this year. So what we're basing our conservative estimate on, what we're calling conservative from a financial standpoint, is precedent agency experience for covering new drugs. We've done this now for 30 years, where for any new drug, particularly one with that has a high degree of publicity, we have seen an uptake rate, and so we're basing that conservative number on that. And then we are then applying that to an average list price of $1,349 per month per recipient. And what these numbers assume is full label compliance. And when I say full label compliance, I want to elaborate a little bit on that. This assumes that patients are compliant, taking the drugs for all 12 months, every week, monthly for all 12 months. And we know that that's not the case. We know the number is much, I'm not going to say much less, but it's more than 25% probably. But for purposes of our projections and ultimately what will be done for budgeting purposes potentially is we are assuming what could be, which is 12 months compliance. And this also does not reflect, again, I mentioned the rebate program earlier. This is total computable or gross costs. So this does not reflect the impact of any federal or state supplemental rebates. And so when you apply the variables below, the list price and the caveats that I mentioned before, essentially that conservative number is about $12.6 million. And if you take our projected state share, which again, I mentioned earlier, we have a 73% FMAP. So apply 27% to that as simple math. The conservative estimate is about $3.4 million to the state. The aggressive scenario, again, we will have more confidence in this as we gain experience. This is just based on the sheer increased general public awareness of this drug. We know from our colleagues in other states that with any drug, with any amount of increased public awareness and other media campaigns, there's a uptick in utilization. In some cases, it goes back down. Some cases, it flattens out. So what this does is assume that variable. And again, that takes the number to $8.5 million from a state share standpoint. So I referenced those numbers with several caveats. One is that we just don't know yet what the utilization is going to be. I would be happy to come back here in 6 months with a better number, but really it's probably going to be 15 months from now before we are able to confidently say what that impact of the state would be. Okay?
Quick question.
Yes, sir.
Go ahead.
We're probably about to ask the same thing.
Well, are you going to have a quantifiable data collection to see what the offset is, what the benefits are of doing this?
Yes, sir. We are much like the GL1 for diabetes outcomes. We will be tracking that. In terms of offsets, one offset obviously is the rebates, and so we'll know what that is. We know what that is now. We know, again, after a year, what that total impact will be on the state share. So that's why I mentioned gross computable cost. We know that there are also several studies relative to the offset to the costs around reduction in medical trend. We've looked at several. There's a lot of experts that say these are valid studies. There are some that are still skeptical. One thing I would say is the majority of the savings from a medical trend perspective are driven by hospital costs. The reason I mention that is because the state share portion in any given budget year of our budget, uh, there's the there's the provider assessment or provider tax function, then there's the general fund component of that. Hospitals largely, there's exceptions, but hospitals for the most part are self-funded. In other words, most of the state share that funds our hospital care it comes from the providers themselves. So there's not a general fund impact. So when we look at savings or offsets, we tend to at least mention that as a caveat. But we are aware that there are offsets. We will be evaluating that as an agency, though. Yes, sir.
Okay.
We will use estimates of utilization. They won't be estimates once we have enough claims run out, but yeah, we will. I mean, we will literally be able to track at the member level hospital costs pre and post. So again, that evaluation is no, no,
And that's where I was headed, Dr. Embry.
yeah. So, that is certainly something that the agency could undertake if this task force is interested in that. It is. It is. We've had our actuaries, our finance people. We have colleagues in other states, and they grapple with it. We are aware of one study I think that was referenced in this task force. Again, we just don't know. There's not enough data nationally, to be quite frank, relative to the impact on medical trend. Yes, sir. hmm It varies by state. So every state is unique. Alabama is very unique with our funding structure. What I would also say is we do track that, and we will track that, and it is important. I mean, the total cost. Number one, there's a relationship to outcomes. So that's one thing I would say is very important. But the total cost, regardless if it's funded from the general fund, a provider tax, or other means, it's still a total computable cost, and that's something that that number is one that we watch every year. In some years we've had double-digit trend. Sometimes hospitals are driving it, sometimes pharmacies driving it, sometimes it's just pure utilization. So that's why it's so hard to really take a study, especially with something that's relatively new, and attribute savings or spend for that matter to price alone or to what's really the offset, if that makes sense. Yep. Yep.
Mm-hmm.
Yep. hmm
To do that.
Yes. I agree. I would say absent a randomized control trial, that's going to be probably years, in my opinion. I'm not an actuary, I'm not a clinician, but randomized control trials are the gold standard. And I just think we need more evidence when we're evaluating offsets or savings. We do know that there are offsets relative to the rebate program. So when we go into budgeting, we look at both, and I think Commissioner Azar does a good job of presenting the total picture, the total cost of the state versus the state share and the different components of that state share. And that's something that's just a daily type of operations routine for us when we're evaluating new coverage, rate increases, or anything of that nature. Okay?
I have a two-part question if you,
Yes, ma'am.
when I'm looking at the cost, the full label cost of the Wegovy, is that the $1,349?
Yes, ma'am.
All right. So is there a trend, or number one, are the other drugs that we see on television all the time, are they about that same cost? And then secondly, if there is a lower cost, are there some trends in the other states that are offering coverage right now of using the other drugs as well, the Mounjaros and some of the other ones that I see on television all the time?
Yes, ma'am. So the way I would answer that is yes, that list price does vary by drug. I don't have the information handy now. I mean, I did on the slide earlier when I showed the 7 agonists that we cover for type 2. I think I had an average cost per recipient that was reflective of 2023. So it does vary by specific drug, and that's something that we could get for you in the next couple of days. Actually, it's just I don't have the information right now, but I would say they're in that neighborhood.
Okay, that's why you do understand why I was asking the question. If there was another drug out there that does the same thing, and if it's a lower cost, that could be, something for us to consider as well. Dr. Parker, what drug was that? Okay, sex. Mm-hmm. Thank you for that.
And I don't want to get you off track,
Yes, sir.
but because I have a short memory and I'll forget what I was going to ask. You touched on it earlier in a slide, was how you purchase drugs. Uh, Terms like FMAP, uh, and how do you get your lowest price? What are the rebates? Can you give us the 1 minute brief on how you actually purchase these drugs? And do you actually know any prices that Medicaid actually pays?
Uh, yes, sir. So one, I would definitely defer some of the specifics of that question to our director of pharmacy and others. But just generally speaking, when I referenced FMAP, that is the federal.
And I say
matching
that
rate.
because nobody can negotiate drug prices better than Medicaid.
Yes, sir. There is a list price, obviously that is on the FDA website, and there is a federal rebate percentage, and it varies by manufacturer. It varies by specific drug. We're not allowed to disclose specific drugs, what those rebates are, but there is some level of negotiation that can be done at the state level, and again, the details of that is something I can probably provide later in concert with working with our
Okay.
pharmacy director.
I'm sorry.
We're not able to disclose by specific drug the rebate amount. Yes. It's not, I'm not going to call it legal, but it is very much a contractual issue where we are not allowed to disclose. We can disclose what the overall percentage is for classes of drugs, the federal rebate percentage and state supplemental, but we as a matter of policy and as a matter of regulation, we do not disclose that at the individual drug level.
But we can assume the feds are going to pay 73%.
Yes, sir.
And then there are going to be some rebates. So if we're saying $1,400 a month, we at least have a rough idea of what you're.
Yes, sir. We do have a rough idea. And what I would say for newly covered drugs, that tends to be greater than 50%. But that is just a very general, broad statement. And so in the case of a lot of these GLP-1s that I referenced earlier, that percentage is higher.
Okay.
So that's why I wanted to mention the gross total computable cost at the outset. Is there are lots of reasons why we don't put rebate information in these presentations, but that's something that we can certainly have a conversation about with our pharmacy director and the commissioner.
I wish you would, because that makes it a lot easier for us to understand what we're getting for our dollars.
Sure. So, but again, I would, as just a general rule, the numbers that you see up there that do not include any type of federal or state supplemental rebate is more than likely going to be greater than 50% for all GLP-1 agonists.
Now, is that information not public, as I understand it?
Yes, sir, that's correct.
Is
At the individual drug
and
level.
is that just so insurance companies won't know, or you don't want to put people in better bargaining positions?
I'm not. I can't answer that actually. Maybe some of our colleagues in the health insurance industry can. Yep. 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 Yeah. And what I would say, I would even exercise caution when Medicaid is presenting any type of one specific drug. I wouldn't even like to use the word estimate because that's just how contractually these agreements are put in place.
And just out of curiosity, the rebate process, can you explain that to us so that I would understand, being an Alabama graduate? I know it's difficult.
uh, I could explain it at a very high level, but again, that is something our pharmacy director, I think you know her very well. She is our subject matter expert on that, and I would respectfully defer those questions maybe offline to her, or we can get that back to the group. Kind of a high level overview of both the federal process that is negotiated with manufacturers, as well as in some cases the state supplemental process. But I just don't want to say anything that's incorrect.
I understand.
Candidly.
I understand. And at a later date, that's information we could probably share with the committee?
Yes, sir.
Okay.
Probably in the near future, next few weeks, probably.
Okay.
Yeah. But I can make sure Dr. Littlejohn and we can get that information definitely before the next meeting.
All right, we'll leave you alone now. You may continue.
Sure.
I'm sorry.
I somehow knew the subject of rebates would come up, and we just err on the side of caution when it comes to disclosing anything that's proprietary.
Well, that's part of the mystery.
It is.
Everything has a cost.
I agree.
Then there's this out in the ether. There's all this other stuff that we don't understand.
Wholeheartedly agree. Okay, so I will end with the second projection that we're putting up here. And again, this is what I refer to as optional, something that for the coverage of just GLP-1 agonists in general that other states are undertaking. We have a little more confidence with our utilization projections, if you will, than we do for the new FDA indication, because we have an organization called NAMD, the National Association of Medicaid Directors, and there's different affinity groups. There's pharmacy, there's finance, there's analytics, and so it's a good time for states. They have state-only discussions, and so we are able to, there's publicly available studies, but there's also utilization information. And so in this particular case, the majority of this comes from some publicly available utilization information. But based on experience in other states, we developed these ranges based upon on an annual basis, not first year, because we know there's going to be a ramp-up period. But on an annualized basis, what we think that if the state covered, again, GLP-1 agonists for weight management, we're using a lot of the same assumptions around list price that we did in the first example. And we're doing a low end and a high end scenario here. And again, the low end effectively is the lowest utilization that we've seen other states, one other state in particular, experience. High end is the aggressive is on the high end. So we feel like we're a little more refined with the range, and we know this is a big range, but those were what went into these numbers. And again, there are so many unknowns. The average patient compliance with these drugs, we're again assuming full patient compliance. We also, again, are reflecting no rebates are included in these costs. So again, currently as it stands now, and I'm not exaggerating when I say these are updated on a monthly or at least quarterly basis for budgeting purposes. Under this scenario, should the state elect to cover that, we think the range would be between 15 and 25 million. Again, that's total gross, total computable, not reflective of rebates. And using our 27% state share, that gets us to between 4 and a little under $7 million. So again, a lot of the caveats that I mentioned in the first projection would apply here as well. And again, there's so much variability with this. It depends on if the state put in PA criteria, what that would be. That could lower or raise the numbers. But you've seen one state with respect to Medicaid in general. So there's a lot of variability in these numbers, just like there's a lot of variability in any type of offsets or any other outcome studies, frankly. So I know this is something that has been asked of the agency um, by Co-Chair Weaver and Representative Oliver rather. And again, there are several caveats associated with this, but we just wanted to show a broad range, albeit, but a range of the financial impact of the state, knowing that it doesn't take into account potential outcomes, improved health outcomes, or any types of medical trend offsets. So with that, that concludes my presentation, and I am happy to take any questions or be involved in any discussion with the task force members.
Senator Weaver? Any questions?
Yes, ma'am. Thank you.
Sure.
Oh, currently eligible for the mandatory coverage. I Oh, so our total population is about 1.1 million. But again, we have criteria in place such as the diagnosis that and we can get you the criteria. We actually had a slide in here, but we took out the details. So the PA criteria whittles that down significantly, obviously. So there are certain diagnoses that are included in this. There are certain BMI ranges. It excludes type 2 diabetics because they are covered under the 7 other GLP-1 agonists that I referenced earlier. So that's information that should be publicly available, but we didn't include it in here. But it's going to be several thousand that ultimately qualify for this. And so those percentages are based on those that would qualify. And that's 18 and over as well, by the way. Sure. I would defer that question to Dr. Littlejohn, who is our Kelly Newman Littlejohn is our pharmacy director. She could get that back to you today. But yeah, she would be the expert on that. I just don't have the details. I apologize.
One question. Medical nutrition therapy. So like looking at the way your regions are kind of broken down, it seems like there are pieces of, so medical nutrition therapy, dietary, RD, registered dietitian, I'm speaking lingo there, but
Sure.
so for that kind of counseling, it seems like some areas have some through that program, and some areas don't. I mean, in general, if I have a patient with Medicaid, we generally are not going to be able to get medical nutrition therapy. Do you have any cost analysis, like in terms of, I mean,
Cost of coverage
Yeah.
of nutrition services,
Yeah.
we do. We, again, there's lots of variables that drive that, depending upon the procedure codes that you cover, the criteria that you put in place. But what I would say is we are actively evaluating the cost to the state. We've met now with ALTA, not to be confused with the Dental Association, but the Dietitian Association. We've met with them multiple times now. They're great thought partners. We are evaluating that. We don't have any firm concrete estimates at this point, but it's something we're in active conversations with them and other groups. We met with the Auburn. I forget the program, but it's Food is Nutrition
Yeah.
folks, and they're a great group to work with. And so they're going to come next week. As a matter of fact, we have quarterly meetings with ACHNs. We call it the Quality Collaborative. We are having that group come and speak to the ACHNs on what their program does. Maybe initially as a QIP project for any part of the state for that matter, but our programs are actively involved in these conversations, and it is not covered, as you know, but we're currently in the process of running different scenarios and numbers.
I mean, I don't know any, national, I mean, same kind of thing in terms of offsetting costs versus, I mean, do you have quality outcomes that happens with with medical nutrition therapy? I mean, yeah, there's some national data that clearly shows that,
Sure.
that would say that, but um, I just assumed that there was some reason from a cost perspective why Medicaid currently doesn't cover from MNT, and it seems like it's, you know,
Largely financial.
yeah. Uh,
So each of that's a great question. What I would say is number one, I think it's limited. I mean, Medicaid funding is limited. So we have a PMPM that is paid to the ACHNs. Part of that is used for general admin, but we require a good portion of that to be spent on these quality projects. Wish we could fund more. So number one, I would say there's a limitation in terms of what they can do with those PMPM dollars. The majority of their payments, the ACHN payments, are related to case management activities and incentives by hitting. They have a numerator and denominator. I would say that the sample sizes, they have improved, but the sample sizes, I don't know that you could really have a robust outcome study with the current sample sizes, but they do track them, and they are based on the adult and child core sets. Obviously, for childhood obesity, the majority of those are the CMS child core sets, but they do tie every outcome to those. Each region, again, has their own. And I would say, frankly, it's a mixed bag. There's some successes. There's other things where, the ACHNs will say it is not working, and then they'll submit another quality program to the agency for approval on our external quality auditor. But to your question, I would not be confident saying there are robust outcome studies or any type of outcome studies associated with the QIPs. But they do, and that's something that we're really proud of with the ACHNs. Is we have I referenced earlier, we have a quarterly collaborative. The way the collaboratives were mandated in the initial RFP, we're going to continue to do those with the new contract year. What it consists of is a 2-day session every quarter. They're virtual right now. We're going to go back to in-person meetings, but all 7 ACHNs are represented. We have a medical director session. We have a quality director session on day 1, and then day 2 typically consists of all staff. And every quarter is a different theme. So next week, again, is childhood obesity. And that's really where we want the ACHNs to facilitate most of the dialogue. The agency's there to set the agenda and to moderate, if you will. But we want the executive directors, we want the quality directors sharing best practices, not only on the quality projects, but when they're trying to hit their quality measures for their incentive program, or what's working and what's not with case management teaching methods and that sort of thing. That to me has been one of the bigger benefits of the ACHN, is just the sheer thinking and dialogue that is shared between 7 distinct parts of the state and in some cases competing companies, frankly. But it is very much a collaborative session, and so those are discussed at length. And what I would say is sample size and the ability to reach more recipients for any given quality project, be it infant mortality or substance use disorder. Medicaid recipients are tough to reach at times, and I think the ACHNs are still working on that. They've gotten much better with engagement rates from the first year of the program, certainly, but there's a lot of room to improve in this new contract. It's a one big lesson learned from not only providers in the community, but the ACHNs themselves and from the agency, of course. It is. It is. That is one of the um, great relationships I think that we have seen form is just the inner dialogue, and starting a medical director only session the last 2 years I think has been beneficial. We instruct the executive directors and instruct our staff, including myself, not to open their mouth if they're not an MD.
I have a question.
Yes, ma'am.
Do you have data on the projected annual cost for the dual agonist for weight management since it's priced lower and is more effective?
I'm sorry, for
For
which?
the dual agonist, the GLP, GIP,
We have not done that at this point, no, ma'am.
because that has more weight loss and is priced lower. And then I have a comment that all GLP-1s are not the same, and this is unique to semaglutide, the cardiovascular benefit, and the data associated with it. So looking at something that is generic or other GLP-1s, they have not shown that benefit in mortality and morbidity. So semaglutide is unique. Whether it's not a class effect at this point, it seems to be a drug effect for this specific drug. And there is a newer drug that is from a different pharmaceutical company that is doing their trial right now. But as far as weight loss goes, that drug is also very effective and is priced lower. So there may be some leverage now that there are two drugs that are very effective for weight management. And there's a significant difference in cost.
Yeah, and in terms of efficacy, again, I referenced that I'm not a clinician, but we have, I'm proud to say we have a new medical director that's been in place for 4 weeks now. Dr. Darlene Traffinstead is her name. She was formerly at the Jefferson County Department of Health. She had a conflict today. She was at least going to be here in the audience to provide moral support. And then obviously Dr. Kelly Littlejohn Newman, our pharmacy director. Our subject matter experts, especially from a clinical perspective, would be available to speak at any time as well.
Okay. Any questions? And since we have a little time and we have stakeholders that are sitting here in the gallery, anybody interested in asking a question? Can't say I didn't offer. Thank you very much, and I appreciate it. Very informative, and it leaves me with lots of questions, which I won't go into now. But is Medicaid interested in any sort of a way to quantify training of your recipients or looking at a holistic approach, diet, exercise, that sort of thing? Is that something that y'all do?
Yes, sir. That's ultimately the goal of the ACHN program is a person-centered approach with our recipients. And so, it's not pharmaceutical alone. It's not nutrition counseling alone. It's the health coaching, it's the healthy eating, active living, and that's something that the ACHNs do well. And so that, again, I think a combination of all those things ultimately is where you could really begin to start to develop an outcome study. But yes, sir, we do think that ultimately is the goal of the ACHN program.
I was just going to make a comment to you, Representative. The reason I was late today is because I was at a grand opening for a grocery store in the city of Fairfield. One of the challenges that we have, even with the education with the recipients, is in certain communities, they're food deserts. They can't get fresh fruits and vegetables. Yesterday, I heard that in the city of Birmingham, within the 99 neighborhoods, 70% of those neighborhoods are food deserts. So there's got to be some type of holistic approach if we really want to make sure that these recipients have access to the food that they need in order to help fight obesity. And I just wanted to add that point.
So, I mean, there have been other pilot programs for Medicaid in terms of produce prescriptions, being able to actually, have Medicaid coverage for, for produce. So I could write a prescription for fresh fruit and vegetables. And so I don't know if that's been looked at by y'all's,
That's actually a conversation. What I would say is a conversation that we had with the Auburn program. And again, they're presenting to the collaborative next week. But we do understand it's a limited number, but there are some other states, state Medicaid agencies that are either looking into that from a pilot perspective or have implemented it. But that's where I would characterize that as very much the introductory stage.
I would like to just comment. Nutrition is so important. I worked in a health system where we had a pharmacy, FARM, where we taught people how to actually grow their own food, and it was in an urban area. Took some dedicated land, and you teach kids good nutrition, they take it home to their parents. So important. I do think that just on from the insurance health plan side, a cautionary note about writing prescriptions for everything, and particularly for food, and it can add enormous cost to something that you could normally get through over the counter or at a store. That once it becomes something that requires a prescription, that a claim is filed, um, that has to be processed, that adds substantial cost. We certainly saw this with some of the CMS mandates around birth control, and things such as condoms that are fairly cheap when they're bought without a prescription become extraordinarily expensive when you go through that process. So while things such as nutritious foods are extraordinarily important, just saying we'll put it through a prescription claim process will frequently make it very, very expensive. So just to be careful with that process. Not that it's not important, not that it's critical that we get good nutrition for children, but we need to be very careful about how we go the process with which we try to accomplish that. Thanks.
And I would say just on that note, it's a great point. We had a great discussion with one of the regions last week about food deserts. But one of the quality programs for, I think it's the Dothan-Auburn region, the Southeast region, which is a Viva UAB entity, they have a school garden program where they're teaching those exact same concepts, and whereby they go into the elementary school, they bring in food supplies, gardening equipment, and they teach. I want to say it's kindergarten through third grade. It could be first grade. I don't want to misquote, but that's one that has been enormously popular. And again, they're looking to expand that in as much as Medicaid funding will allow, but it's something that's probably since the outset of that particular program, that is something that the other ACHNs, to your point earlier, have really sought as a best practice, and some have started implementing their own. So again, I wish it was more at scale. Again, the sample size limits us in certain cases, but that's a perfect example of what these collaboratives are about.
Interesting. Any more questions? We're going to get out of here before noon. Next meeting? We will send you an email because I'm not prepared for that at this point. We'll check everybody's schedule and see where we are. With that, Senator Weaver, any comments?
Yes, ma'am. Thank you, and I appreciate the opportunity to present on behalf of Medicaid.
Thank you very much.
Thank you.
And with that, we're adjourned.